The opinions expressed by the host and guests in this show are not necessarily the views of Children's Health Defense.
Good morning, CHD. It is Monday, the 16th of June, 2025. We're live here at CHD TV. So we have a little bit of a different show for you today. Brian Hooker, sadly, just a few minutes ago, had to pull out due to a personal issue. And so we respect that. And so we are going to have a show that's a little bit different. I'm going to just read you a few headlines, not headlines, but just a few notices in a minute. And then Dr. Stu, very kindly, who is going to be coming on with Bella, has offered to have a little chat with us. So if you've got any questions for Dr. Stu on pregnancy or anything like that, do send them in the chat and we will get through this show. Yes, we will. All right, everybody. Well, now, yesterday when I was on with Mary, I promised you that we would show Robbie Rose. Now, Robbie Rose was our amazing little comedian that worked for us at CHD TV back in the day. And she did a very funny sketch of the ACIP meeting. You've all seen the professional one, the one that's gone out, the formal one. Now, take a look at Robbie Rose doing her one.
Healthcare personnel who have direct patient care responsibilities have higher coverage than that, whereas those without direct patient care responsibilities have lower coverage. And that was sort of the average of all healthcare personnel.
Dr. Walter?
Yes, with the number of adjuvanted vaccines now available, including flu vaccine and Shingrix, is there any comment on using this vaccine at the same time with other adjuvanted vaccines?
We have no data to make a recommendation one way or the other.
So just to sort of put this in context of other vaccines, whilst preclinical studies were not done using these vaccines simultaneously, our general approach to immunizations is that they can be given at the same time in different limbs.
Dr. Hunter?
Are multiple adjuvanted vaccines used in Europe or other markets?
Dr. Ward, do you want to comment?
Not to my knowledge.
Thank you. Okay, I think unless there's any further discussion, we will take a vote on this recommendation.
I want to remind everyone to please check your voting whatever machine thing, and I don't know what it is, and check and make sure it's on channel 71 prior to voting.
Thank you very much. So the voting is completed, and it is unanimous to support this recommendation. Thank you all.
She's so talented, is our Robbie Rose. So that little clip there will be in our on CHD TV, so you can share it out there. It kind of explains it better than the other one, to be honest. Right, the other thing to tell you is this Sunday we are going to be airing a documentary after the Mary Polly show, 5G, The Untold Story. It's super good, and we're very excited that the filmmakers have let us air this documentary. So that will then go into our movie section. You'll be able to share that. And also to let you know that throughout July, we're going to be playing a lot of the Gary Null movies. He's given us pretty much all of them, and we are going to be airing those for you. So it's a big movie month in July. And I think that's it for my little notices this morning. I hope you're all doing really well. I'm going to bring on Dr. Stuart. Dr. Stuart, thank you so much for standing in last minute.
You're welcome. It's my pleasure.
Good old live TV, eh? Well, I've got a question for you, and I think our chat are going to be asking you some questions as well. And one of the biggest questions is morning sickness. What can you tell us about that? Because some people, there's a lot of different views on what you should do. So some people say it's because you're lacking in something and that's why you get sick. And some people just say, it's a really good sign that you've got morning sickness. It means your HCG levels are really high. What's the deal on morning sickness?
Well, first of all, it's a misnomer because it's not just in the morning. But yeah, it can be caused by many things, but high HCG is one of the things that can trigger it. Hyperthyroidism can trigger it. Obviously, having multiple gestations where you have higher levels of HCG can trigger it. And then there are emotional and psychological components that can trigger it. And it's not just one disease. It's not just one problem. I don't like calling it a disease. It's the body's physiologic response to things. Why it happens is a really interesting question. What's the evolutionary benefit from it? And that one is a theory that's quite, beyond me. But some women don't have any, and then in a subsequent pregnancy they'll have some, and then they wonder if that's because there's something different about the pregnancies. No one can really explain that issue. But what you can do if you start to feel nauseous in pregnancy is several things. You want to eat small meals frequently throughout the day. You want to maybe eat 7 or 8 times a day, very small meals, high in protein and carbs. That will help. You also want to, eat when you wake up in the morning. Having a protein smoothie is a good idea. And when you go to bed at night, you might want to have a snack, like a protein snack before bed, and keep something protein on your nightstand so that when you get up in the middle of the night to pee, you might have like a spoonful of almond butter or a hard-boiled egg or something like that, just to keep your stomach busy doing things all day long. Acupuncture can help if you have it. Small meals, as I said earlier, frequently throughout the day. And then vitamin B6 tends to be a useful supplement, it seems like, and it seems innocuous enough that you could try using vitamin B6. And it comes in a medicine that you can get over the counter called Unisom. You can combine it with a medicine over the counter called Unisom, and it makes a medicine that used to be called Bendictine, and now you can get prescribed Diclegis. But if you want to avoid pharmaceutical products, then you can just take B6 and Unisom over the counter by yourself to do that. There's also Zofran is another medication. Again, in my world, we try to avoid pharmaceutical products. We have a natural suspicion of them. And because there's natural remedies that you can do to help, you want to try to avoid those sorts of things. And there's lots of homeopathy, and quite frankly, Polly, I'm not an expert on homeopathy, but you can look that up, or you can ask a midwife. They tend to know a whole lot about the different herbs and homeopathy that you can use for that. And then also you want to look into, what's going on in your life. Can stress contribute to that? Can being unhappy with your partner or being unhappy about being pregnant trigger that? So there's lots of other components that go along with it. And sometimes if somebody has severe hyperemesis, they may need IV fluids. You want to check their chemistries to make sure their electrolytes are not screwed up. But generally, it's transient. It lasts the first couple of months, then it goes away. As you said, it is a sign that you probably have a viable growing pregnancy. Right. So if you're nauseous and then the nausea disappears early in the first trimester, that's not necessarily a good sign.
And just to say to our viewers here, okay, obviously our viewers are hardcore anti-pharmaceutical anything, just because we're so afraid of it. We've all had nasty experiences from it. So just remember that Mothers-to-Be is really about getting you guys information, and you make your own minds up on it. Don't trust anybody, just trust yourself and your instinct. Well, we've got a few viewer questions coming in. Someone's asking about induction for older age. She's 43, having a baby. They are pushing for induction at 38 weeks, claiming it is due to risk of stillbirth. Also asking about cascade of intervention. If she wants an epidural, is she more likely to end in a C-section?
This is one of my favorite topics because this is just shows the obtuseness of the medical profession. Listen, I was part of it when I came out of residency. I was well trained and I came out very medicalized. But what this woman is being told, most of it is can I say BS on Children's Health Defense TV? Yeah. What they're doing is they're using scare tactics to funnel a woman down a path they want them to take. And they'll always, first of all, being over 35 is not high risk in and of itself. It got labeled high risk years ago when the risk of amniocentesis and miscarriage prior to the era of ultrasound equaled the risk of having a Down syndrome baby. And that happened to cross, those lines happened to cross at age 35. And that is where that age 35 came from. And then it just stuck. And let me ask a very simple question to your audience. Which is riskier, being over 35 or having induction of labor? And if you answered induction of labor, then you are correct. Induction of labor carries much more risk than being over 35. Yet the one that's over 35 is the one that's labeled high risk. So high risk is not a number, Polly. High risk is something that makes the doctors uncomfortable or is an algorithm that they're just following. And the idea that the risk of stillbirth rises because you're over 35, well, the truth is the rate of stillbirth rises in all women, in all pregnancies, whether they're singletons or twins, once you're beyond about 36 weeks. So it's not important that the rate of stillbirth rises. What is important is how much does it actually rise? And this is the thing that doctors probably don't know and certainly aren't being honest about it because they're using relative risk. They're saying, well, the risk is twice as great. Okay, well, what does that mean? Twice as great as what? What's the denominator? If something happens 1 in a million times and now it's twice as great, it's still 1 in 500,000, which is essentially still 0. So the risk of stillbirth at 38 weeks or 39 weeks in a woman who is over 35 is not any significantly different than a woman who's 25. And it doesn't rise rapidly. It's not astronomical or I can't think of the word right now, the fast rise on a graph. It doesn't just shoot up like that. So the risks of induction are probably greater than the risks of stillbirth and leading to that cascade of interventions that your questioner asked about. So I don't know how we change the culture in this. Because doctors are trained in this. They're trained that pregnancy is a problem, that you're treated as when you go to the hospital in labor, what do they do to you? First of all, they ask you questions as if you're coming in with a ruptured appendix. Secondly, they put you in a hospital gown. Thirdly, they put you in a bed, right? They're treating you as if you're a patient, and it psychologically has you at a disadvantage because now you're thinking that there's something wrong with you. And the American College of OBGYN is not an organization that I have a lot of respect for anymore. Even in one of their statements says that pregnancy itself is a high-risk condition. And if this is the prism by which doctors are seeing pregnant women, then we can understand that they see everything as potentially high risk. And this is just another thing. And see, all they really want is a live baby in the bassinet. And if that baby gets in the bassinet and it's alive, they don't really care what happens to that baby. They don't know what happens to that baby a year from now or 2 years from now. How's that baby doing? How's that baby's microbiome? They don't really care what happens to that mother. How's that mother doing? How's breastfeeding? How's she doing 6 weeks later? How is her experience? Did she experience some trauma in birth or some PTSD? And they don't really care what happens to her future babies. And yet all these things, there's a ripple effect downstream when you interfere with Mother Nature's design. So to this specific questioner, challenge them. Ask your doctor, well, doctor, being that I'm 35 or whatever age I couldn't remember what I think you said, 35, did you say, Polly?
I think she said that, yeah. I can't remember. Let me have a look. No, she's older, I think.
38?
43.
Oh, she's 43. Still, again, the risks do not rise statistically to a significant point where induction is a better solution. They can monitor the babies if they want to, all right? And if the babies seem to be testing just fine, then there's no reason to intervene. Nature has a design, and when we mess with it, we cause ripple effects downstream. She should ask her doctor what the actual risk of stillbirth is. And I can pretty much willing to bet a good $10 that they don't have any idea what the actual risks are. And there are good articles out there that put tables together that show this. And so you can look that up on your own, and you can go to your doctor and you can say, you can come in well informed. Don't let them scare you.
Well, this is it. This is what I want to talk to you about. I cannot believe the scaremongering that goes on with these young pregnant women these days. There was one woman told that she needed to abort her child, I don't know, halfway through her pregnancy because it was completely deformed and that, it wouldn't be able to survive for 2 seconds after. But she said, I'm strong, have strong faith. I'm just going to go with it. Absolutely fine, that baby. Nothing wrong with that baby at all. How can they make such a catastrophic mistake by saying that? And we have so many horror stories like this, I can't tell you. And all the scans that these poor young women have to have, and they scare them. They scare them with, oh, your
Yeah.
placenta or whatever. It's in my day, we had one scan and we were left alone.
Yeah, well, in 1970, about 1/3 of women had an ultrasound. Now, about 90% of women have at least 3 ultrasounds. And by the way, with no concern about the effect of ultrasound on your developing fetus. Ultrasound is a form of non-ionizing radiation. And we don't know what that does. And no one has done a human studies subject test on ultrasound since the late 80s, and I think that was in China. So we don't really know. The machines have gotten more powerful. There is now much more use of 3D ultrasound and color Doppler flow ultrasound, which are higher intensity. These things are overused. Part of the reason they're overused is because they can, the doctors that are using them and the radiologists that are using them make more money when they turn on the color flow Doppler. And here's a simple question that whenever you're asking whether something is valuable or not, ask the question, since the use of color flow Doppler, which has been in the last 15 years, the emission creep, it started out being used solely for things like growth restriction and following babies, but now it's basically turned on at every ultrasound. But since they started doing that, have outcomes improved? Are we doing better with our babies? Are we doing better with our mothers? And the answer is no, we're not. The C-section rate continues to rise. The induction rate continues to rise. As a matter of fact, in the last 15 years, the rate of newborn intensive care unit admissions in the United States has almost doubled in 15 years. Now, here, the cynical part of me says it's doubled because there's more money to be made by putting a baby in the NICU. But if that isn't the case, then why are twice as many babies ending up in the NICU if we're doing so good with all our color flow Doppler and our surveillance and all the testing that we're doing? So I'm just saying that people need to stop and take a look at the system and realize that they're always using safety as a canard to get you to do what they want you to do. There's a French philosopher, Albert Camus, who said the welfare of humanity is always the alibi of tyrants. And what doctors do because they're scared is they will use those tactics to get you to do what they want you to do. And they'll make you feel weird or funny, or they'll even pit your baby against you if you choose to go a different path.
Well, thank you, Dr. Stu. I have a ton more questions, but this is not my segment. It's Isabella Yon's segment. So I'm going to hand the show over to her. To our viewers, so sorry about the this morning and having a different show for you, but it's kind of fun talking to Dr. Stu. And I'm going to hand over to Bella now. Dr. Stu, thank you so much for everything that you do for all those women out there and for helping Sarah from Tea Time viewers. She is overdue. And she is hopping around, doing her thing, trying to get her little baby boy out. But just so you know, I'll let you know when that news comes in. So be praying for Sarah. At 43, by the way, she's 43 also, to that person out there, and she's doing fine. You can be 43 and have a baby. Right, Isabella, welcome to the show. I'm going to duck out now and let you take over.
Thank you so much, Polly. Welcome, guys, to Mothers-to-Be segment, where we chat all things pregnancy, preconception, birth, and postpartum. Dr. Stu, welcome back. Thank you so much for chatting with me. When we had you on a few weeks ago, I think it might have been even a few months ago now, we had so many questions after you came in about all sorts of things. But one topic that kept coming up a lot was RhoGAM. And I think one of the biggest questions people had, which I would love if you could just start us off here, is what even is RhoGAM and why is it offered during pregnancy?
Okay, RhoGAM is a pooled blood substance that contains anti-rhesus factor, mainly anti-rhesus factor D, and it is one of the few things in medicine that, when used properly, has really been a miracle. Rh negative women who carry an Rh positive baby and the husband's blood type needs to be Rh positive, obviously. They're at some risk, and it can't be quantified because we don't always know what causes a woman to be sensitized, or even if a Rh positive father may have an Rh negative baby if the father is heterozygous, which I don't want to confuse people about that. But there's a small chance that some blood from baby, which is Rh positive, gets into mother's circulation, and the mother will then develop antibodies against the rhesus factor positive antigen. And that will probably not affect that baby. But if she's pregnant with a Rh positive baby a second time, that baby can get very affected and become very ill in utero. And prior to the era of RhoGAM, about 1 in every 2,200 babies died from Rh disease, and about 1 in 100 babies was affected by Rh disease. So since that RhoGAM has come into play, that has fallen dramatically, and we don't really see babies dying from Rh disease of the newborn anymore.
Interesting. And so when is it usually given? As a pregnant woman, when would you be expected to be given this? Is it during pregnancy? Is it after birth? How many doses? Things like that.
Okay, well, this is where it gets controversial, and especially in the era of spike protein and COVID, and we'll talk a little bit about that. Prior to this era, it's only been studied for postpartum use. And then let me be accurate about the history here, because it's really interesting. There were clinical trials there were 9 clinical trials from 1967 to 71 that showed it was effective, and it was recommended to all Rh positive moms who had Rh negative moms who have Rh positive babies. Because if you don't give it and you're an Rh positive mom, you have a 7.2% to about 12% chance of of being sensitized in that pregnancy. So that's after the baby is born. That's not during the pregnancy. So it makes good sense for an Rh negative mom who gives birth to an Rh positive baby to get RhoGAM. Okay, that makes good sense. Using it at any other time has not been studied well. And like many things in the pregnant world, in the medical world, we're often doing things because it sounds good or because a consensus decided it was good, but there's actually no good science behind it. And the most common time that women are given RhoGAM is at 28 weeks. The 28-week RhoGAM dose was never studied. So there's no data to suggest that it actually does benefit or not benefit. And now, because it's standardized, you can't do studies. You can't ethically take 1,000 women and give 500 of them RhoGAM at 28 weeks and 500 not RhoGAM at 28 weeks and see what happens, because it's now become the standard of care, and to try to do that. So it's a perfect con, really. It's kind of like, to just digress for a second, it's kind of like vitamin K. About 1 in 16,000 babies who will get vitamin K deficiency bleeding postpartum. They give vitamin K to all 16,000 babies. No one's going to study as to maybe we should find out what's wrong with that one baby instead of giving it to 16,000 babies. So same thing with RhoGAM. We don't know why some women get sensitized and some women don't. But we're never going to study it anymore. Part of it, the cynical side of me again says there's no money in not giving RhoGAM, and there's a lot of money in giving RhoGAM. So RhoGAM is offered to all 28-week women. What's interesting is you're not supposed to get RhoGAM at the same time you get vaccines, because it's an IgG product and it could interfere with the vaccine doing its work. But what else do doctors offer you at 28 weeks? Besides RhoGAM, they offer you the flu vaccine, the COVID vaccine, and the DTaP vaccine. So if you're one of those people that wants those things, ask your doctor to maybe delay giving you the RhoGAM, or give the RhoGAM and then get the vaccines later, or vice versa, but don't do them at the same time. But just know that there is no data to say that giving it at 28 weeks has any benefit. Other things that they might suggest they give it to you for are things like if you have CVS or amniocentesis, if you have an unexplained antepartum hemorrhage, especially outside the first trimester. there's pretty good data that says if you have a miscarriage early in the first trimester and you're an Rh negative woman and you have an Rh positive partner, that RhoGAM is probably not necessary, yet it will still be offered to you. Ectopic pregnancies, molar pregnancies, which are something I'm not going to talk about today, but they're weird tumors. A stillbirth inside, and whether you get delivered vaginally or by cesarean section, RhoGAM will be recommended. Now, some of those things are legitimate. Some of those things are just consensus opinion. But there's really no good data. And I don't like doing things without good data, especially since RhoGAM may or may not be innocuous. And RhoGAM, can I keep going?
Yeah, please do. This is fast.
RhoGAM is one of those rare medications. And I want to credit Sarah Wickham from her book, Anti-D Explained, because she gets all the credit for what I'm going to tell you next. But you're supposed to give RhoGAM within 72 hours of an event, whatever that event might be. And if it's birth, you're supposed to get it within 72 hours. But actually up to 10 days is probably reasonable. 72-hour thing came from the way they actually tested this on prisoners, and they only had them for 3 days. So that's where the 72 hours came from. Medical history, by the way, is very interesting for those of you. I happen to be a bit of a geek on it. But this is the only medication that I can think of that is given to a person who doesn't benefit from it. In other words, you're giving it to a mother who's not getting any benefit from it at all. Secondly, when given in pregnancy, it may cause possible detriment to another person who also is receiving no benefit, and that's the baby inside of you at the time. You're not giving the RhoGAM to protect the baby inside of you. You're giving the RhoGAM to potentially protect against problems with future babies. So you're giving a product that may have a downside to the baby inside of you, and it has no benefit. So you can't calculate a risk-benefit ratio when the benefit is zero. Think about that for a second. We're giving a medicine to a woman who's pregnant that has no benefit for the baby inside of her, and yet may have some risk. And then thirdly, it's given, this is the only medicine that's given to benefit a person who does not or may never exist yet, right? So it's a very unusual medicine, and it is a medicine. And as I said, it's a pooled blood product. It comes from usually male Rh negative men who either by risk of a transfusion or voluntarily were sensitized to the Rh antigen so that they can then collect their blood and then filter it out. Now, I will say that there is no aluminum in RhoGAM. It is filtered extensively. The process to filter out things like hepatitis C and hepatitis B and HIV, those things are filtered out. And there have been really no reported cases that I could find of these things being transmitted from a RhoGAM product. But the question is what's it doing with now in the last 3-4 years where donors have gotten vaccinated? They do not screen out COVID vaccinated donors for RhoGAM. So theoretically, there could be spike protein in the RhoGAM. Do you want me to talk more about that?
Yes, please expand.
Okay. I don't know. I'm monologuing the whole thing here. So
I love it.
I went to a couple of sources and then I bounced it off ChatGPT, like a lot of people are doing nowadays. And there are no publicly available studies testing whether spike protein from vaccinated donors remains in RhoGAM. They will tell you that the purification process is very thorough. But again, people in medicine and pharma have told us lots of things. So I don't know what to tell a woman who's concerned about that because there is no safety validity. So you're justified in questioning whether or not RhoGAM is safe from the spike protein because, again, there's been no testing for it. The current safety assumption is based on historical manufacturing and epidemiologic observation. Like there's been nobody who's reported getting a problem with spike protein who's gotten RhoGAM. But about 10% of women who get RhoGAM, by the way, are going to have side effects from the RhoGAM. Sometimes it's just local injection. Sometimes it's fever and chills and aches for a day or two. And in rare cases, there can be anaphylaxis. It's one of the products that's in there. So it's not innocuous. It is probably beneficial to be taking postpartum, or if you've had a significant abruption of the placenta or some other event in pregnancy where there's a potential for blood mixing from the baby into your bloodstream. There is a test that can be done. It's got a funny name. It's called the Kleihauer-Betke test, which can check for fetal cells in the mother's bloodstream. And sometimes that would be valuable to do that before getting the RhoGAM shot to see not only do you need RhoGAM, but maybe you need 2 amps of RhoGAM, depending on how much blood was put into you. You know, they have a one-size-fits-all shot. Everybody gets a shot of RhoGAM, usually in the hip is where it goes. So that's sort of in summary.
Yeah.
I hope that answered that and other questions.
That was fantastic. Thank you. So I know you touched, I've got so many questions, but I know you touched a little bit on like risks and side effects, specifically focusing after, you know, when these women are given it after birth. Are there any like known risks or side effects to the fetus if they were to get that at that 28 mark in pregnancy? Do we know anything about that?
Well, we know that RhoGAM is an IgG product, immunoglobulin G product, which does cross the placenta. So in theory, it could cross the placenta and cause some of the baby cells potentially to be attached to the baby cells because they're Rh positive, and maybe those baby cells would then be destroyed to some degree. It hasn't been clinically obvious that that happens, but again, no one's tested it.
Yeah.
So Bella, no one's looked to see what's happening to babies. This is one of those things that happens where they find a product that's really good for a specific indication, and because it's a very limited niche, they want to expand the niche, and so it starts to have what's called mission creep, and it starts to be used more and more for things that aren't necessarily it's indicated for, because two things: one, they think it's innocuous, and 2, it generates revenue. Yeah. So people, again, I can't tell people what to do. I can tell them that if they're spotting in the first trimester or the second trimester, their doctors could probably going to recommend RhoGAM. And what you need to do is you need to question your doctor to ask him, what's the evidence that I need RhoGAM for this? Is there a way to test whether or not I've been sent, my baby's blood has gotten into my body? And by the way, if you miscarry at 6 or 7 weeks, there isn't enough blood in the developing fetus, or even if there was a fetus, it could be a blighted ovum, to actually sensitize you. So why are you getting RhoGAM? These are all logical questions to ask.
Yeah, thank you so much. When we had questions coming in, you know, all those months ago, one question that really stood out to me, which I think you'd be great at answering, is in the situation, the mother, she knew this was going to be her final baby. She was actually getting a C-section that was planned, and she planned on getting her tubes tied during the procedure, but they were still pushing RhoGAM, saying that it could be harmful to her and her baby. Would you mind touching on that? If you aren't planning on having any babies, do you still need RhoGAM?
No.
Okay.
No. The one thing that might happen they've purposely sensitized men to be donors for the RhoGAM program. So how dangerous can it be to be sensitized if you're not pregnant or you're a male? So the answer is no. The only thing that would happen theoretically is if you get sensitized is you no longer could ever be a blood donor.
Okay.
That's the basis. You know, when I rack my brain for reasons why you need RhoGAM in that situation, there isn't one.
Okay, fascinating.
I'm not saying that I'm not missing something, but I'm pretty good at this sort of stuff. And it just makes no sense to me that, you know, we sensitize men to get donors for the product, but if a woman isn't going to have any more babies, then why does it matter?
Yeah.
I suppose theoretically anybody who doesn't want more babies could have an oops down the road. So in that case, yeah. But if you're getting your tubes tied, that sort of thing, it seems very unlikely that you would need to get the RhoGAM shot and take the small, slightly greater risk from getting RhoGAM that brings to you. I do want to reiterate again, because I've just pointed out a lot of the problems with the studies about RhoGAM and the RhoGAM itself and its overuse in certain things. But it has been a miracle. Because again, about 1 in 10 babies used to be affected. by this, and 1 in 2,000 or so would die. And now it's like 0.2% of Rh negative moms who have Rh positive babies whose babies will still have a problem. So RhoGAM isn't 100% effective, but it's drastically improved the outcomes. And so it is one of those miracles when used appropriately in medicine.
Yeah, thank you. And I was going to ask you, flipping to the other side of things, what kind of risks to the baby, like what does that look like if a mother was to decline RhoGAM? What are the potential risks that she is looking at with her baby?
If she declines RhoGAM with the baby that's in her uterus?
Yeah, before and after, if she declines.
Almost none to that baby.
Okay.
Because initially when you get sensitized by the Rh antigen as an Rh negative woman, you for the first few months, you create something called IgM. IgM is a bigger molecule. It does not cross the placenta. And only after several months does IgG begin to take over and IgM disappear. So if you get sensitized in that pregnancy, it's very unlikely to affect that baby. So that baby gets, as I said earlier, is one of those things that gets no benefit really from the RhoGAM. Whereas the mother's future babies will benefit greatly from it should she get sensitized. To prevent that sensitization is what I mean.
Okay, yeah, thank you. And then what does that look like for a future baby? Is it sickness?
If a mother is sensitized and she gets pregnant with an Rh positive baby,
yes.
that baby can have, you've got the things up on the screen, that baby can develop all the way from anemia because it's hemolyzing its own blood cells, which then causes it to be jaundiced. It can get edematous, it can get heart failure, it can die in utero, it can get something called hydrops fetalis, where it's completely edematous and you can have an intrauterine fetal demise. They can deal with that, but it's very involved medicine. You have intrauterine fetal transfusions of blood. You bring the baby out early. It's a bad thing when that happens. But remember, it affects about 1 in 100 babies, but it only about 1 in 1,000 would have been 1 in 2,000 were killed even back before RhoGAM. So a baby that's affected isn't necessarily going to die, but it is going to make it a truly high-risk pregnancy where you might have to have invasive procedures done to help get that baby to viability and then have that baby be born early and spend time in the NICU, that sort of thing. So, yeah, obviously avoiding it is the best possible remedy.
Sure. Yeah. Thank you so much, Dr. Stu. I really appreciate your balance when it comes to this. And that's really what we're about at Mothers to Be, is presenting this information to women and then allowing them to make their own choices, but really looking at the pros and cons of both sides. So I really appreciate that. Just to wrap up, I know you mentioned that one book. I'd love to pull that up on the screen again, but do you have any other kind of resources for women who are wanting to make an informed decision on RhoGAM? Or is it all in that book?
Actually, it's all in that book, plus the references involved in the book. There's other resources you can go to for that too. There are lots of papers on it, but they're all old because no one, as I said earlier, now that it's an accepted therapy, no one is studying it anymore. So there's really nothing new on RhoGAM.
Yeah.
I think the last study that came out was in 1997. And by the way, most of these studies are not they're retrospective reviews of mothers' records. So they're what's called level B or even level C evidence, which is consensus opinion. And when you get a bunch of maternal fetal medicine doctors in a room making decisions with big pharma and scientists, and there's no midwives there, there's no lay people there, there's no mothers there, what kind of consensus do you think is going to come out? And that is that it's recommended now to be giving at 28 weeks and to give it for all these things that we discussed. And that's level C evidence. So that's just opinion only. And then no one, again, because now it's accepted, no one is going to do a study where they look at women who chose not to get it versus women who get it, because they won't have enough of those. It won't be ethical according to the way they do studies. They'll say it doesn't meet human subjects testing. And so no one's ever going to test it anymore. So there isn't a lot of new data, but the old data does confirm the use for postpartum use. It makes good sense, but there is no data that's good or even at all that supports its use for any of the other things that we're talking about. It was just empirically given because it works so well for postpartum.
Fascinating. Thank you so much, Dr. Stu. This was so thorough. And could you please also share your website with people? I know you cover so much on birth and exactly what our readers are looking for. So I'd love for you to direct them there and any other resources that you have. And I know you host a podcast, so please.
Well, thanks for having me on, Bella, because this is made a refresher course for me because, you know, I know these things, but when you don't use them every day, you have to go back. So it was really refreshing to go back and read Sarah's book again. And yeah, my website is birthinginstincts.com, and my podcast is birthinginstinctspodcast.com. And I've published some papers on home, twin, and breech birthing, which are on my website. They're open access, so they're free, and people can click on them and read them. And and my passion right now is to try to change the way we look at birth, even if it's one family at a time, and to keep the skills of breech and twin delivery alive, since my colleagues in academic medicine have decided that cesarean section is the be-all, end-all, without any real concern about what happens downstream to this generation and to generations to come. So I go around the world and I teach a 2-day seminar. I do about 12 of them a year, and we have a hands-on simulator, and we have more than one hands-on simulator. And we teach the skills that are necessary because any birth worker is eventually going to come up with a surprise breech. Surprise twins are rare these days. They do happen, but you know, it used to be 50% of twins were diagnosed in labor until the era of ultrasound, and now it's really rare. But we know that breech birth is going to be fairly common in twins. More than half of all twins will have at least one baby in breech position, and if doctors don't know how to do that, then they shouldn't be taking care of twins, and yet they are. And they're the ones that say that midwives shouldn't be taking care of twins, when midwives are the ones who are knowing how to deliver twins safely and properly vaginally. It's all backwards. The research is backwards. The propaganda is everywhere. It's a tough time as a person trying to decipher the data of what to do. And the spike protein issue is not going to go away. And again, if no one's looking, you know, we're all guinea pigs. So yeah. I don't know. Yeah, everybody has to assess their own risk benefit.
Absolutely.
But there is a real risk to getting sensitized from a vaginal delivery or a cesarean delivery of a term baby or even a preterm baby. So that is a serious consideration where RhoGAM would be something that I would consider being reasonable.
Amazing. Well, thank you so much, Dr. Stu, for just your thoroughness on this topic and your expertise. We always love having you on, and I'm sure people will be sending more questions in for another show later down the line. So yeah, guys, make sure you check out Dr. Stu's website and his podcast and just all the wealth of knowledge that he has to offer. And remember, knowledge is power. That's why we do what we do, just so that we can be educated and informed mamas and make the best choice for our kids ultimately. So thanks so much for tuning in. And now we are going to go to our story of the day.
Tell us your name, please.
Melissa.
And who are you?
Harrison.
How old are you, Harrison?
7.
7. Thank you for being here. Now we're going to talk about your 2 daughters.
Yes.
So tell us what happened and how old they were.
His mom, I thought I was doing the right thing. I gave her the HPV vaccine. Right afterwards, she started having a lot of inflammation issues, abdominal issues, had her appendix removed. Doctors never connected. She couldn't go out bowel movements. They just wanted to put Band-Aids on everything. And we weren't connecting the dots. I didn't connect the dots that she was also injured from childhood vaccines because she was nonverbal. Doctors put her through 5 hearing tests. Hearing was fine. Finally got speech after we went to school with getting help from speech therapist. And then after giving her the Gardasil, it took about 8 years for it to fully catch up to her. Started going to naturopaths. Naturopaths determined her immune system there was no immune system any longer. She battled with ticks a lot of ticks, Tourette's, and she decided she was going to go into the medical field. She wanted to help people, and then they required all their, I'm going to call them as I call them, jabs. They required their jabs. She continued to get sick and sick. Decided she didn't want to work for what I call medical mafia. It's sick care system. You know, they got to keep you sick to get their money. And then after she turned 21, she just continuously couldn't stop vomiting. Couldn't stop. I feel responsible a little bit because I didn't believe her. I didn't understand how somebody that's so young could be so sick all the time. She ate a lot of ibuprofen because of the pain she was in. She ended up dropping down to 80 pounds. She was skin and bones, no muscle mass left at all, none. But I believe in God. Holy Spirit came to me and he said that ivermectin that you've been giving your friends for the COVID, I want you to give it to your daughter. And I'm like, really, God? And I trusted the Lord, and I started giving my daughter ivermectin, and then she started feeling better. And it's been an uphill process since then. She's 90 pounds now. We're working on restoring her immune system. I learned that what was going on with her when I watched Judy Michaelvitz and Reawaken America tour in Salem. And she showed pictures of girls that were Gardasil injured. And that's when I connected the dots, that it was she had AIDS, autoimmune disease syndrome, which is what it is. People need to figure out the truth on that one. And my other daughter struggles with migraines, massive migraines. She has POTS. She just passes out for no reason, even though her vitals are perfectly fine. And thankfully, when we started connecting the dots, my grandson had his immunizations, had 3 seizures the first year of his life. Magically, they just happened to be a week after vaccines. Doctors denied that it came from the vaccines. Then he got really, really, really sick. His first Christmas, I think it was he was super, super sick. But at the age of 2, took him in for a well-child visit. He got more vaccines. He went nonverbal. He didn't want to have any engagement with kids. And yeah, I feel like it's important for people to know the truth. I don't think vaccines are vaccines. Vaccines are supposed to be cures, and they're not cures. They're creating a lot of problems. They're loaded with a bunch of heavy metals, and they go to the brain and also affect other areas of the body. But my God is a bigger God, and he's healing my daughter, and we're just on the uphill path.
Melissa, what did they say to you when you took your daughter in for her Gardasil? Why? Because it's not your fault. They would have said something to you about why she needs it.
I was a little pressured a little bit by a client of mine that, I was going to be preventing cancer on her.
See, there you go. So they basically said that your daughter would not get cancer if you gave her the shot, any kind of cancer.
When we did it, that's just they didn't actually say anything, to be honest. That's just what the word was out there, that you're going to be preventing cervical cancer and preventing HPV. Well, guess what? My kid still got HPV because they injected HPV into her.
So she got HPV after the shot?
Yes, after the shot. Yep.
And she didn't have it before?
No. So.
So what is your message to the young mum who's about to have a baby and doesn't know what to do anymore.
Fight for your kid's health and don't inject them with poison. Don't do it. Don't fall for it. My daughter, his mom, who's heavily injured, 28 vaccines for her. My other daughter, 25 for her. Excuse me, not vaccines, because they're not vaccines. They're jabs. And he, before he was of 2, which we didn't even realize this at the time, till we went to look at his 5-year-old, we realized that they gave him not only his 2-year-old vaccines, but they gave him his 5-year-old vaccines at the same time. So he's had 28. We're starting to see some of the same things with him. Thankfully, his mom did detox baths on him every other night. Did detox baths on him. We had his speech back in about 6 weeks. People at our church were like, wow, yeah, we're detoxing all the heavy metals out of him. And we have a success rate with him. I understand not everybody is, but then he wanted to start playing with kids, started talking.
So what kind of things do you like to do? What's your favourite thing?
Play Minecraft.
Minecraft. You and the rest of the world, it seems. What else do you like doing?
Going to the park.
Going to the park? That sounds good. Wow, you're doing really well.
He's a blessing for us.
You certainly are.
And the fact that his mom connected the dots and just immediately reversed, tried doing everything she could to reverse and get all these injections out of him, to where we had a boy that wanted to play with other kids. And so his mom, I have to live with what I did.
Melissa, we all do. Thank you for telling us story and warning us all. Thank you.
No HPV, no shots at all, none. They're not what people think they are. God gave us an amazing immune system, and why are we injecting metal into us? I don't only just disagree with the injections, I disagree with Big Pharma. A lot of the drugs that they put people on. And right now, creating memory issues for our older people. They didn't get them with as many vaccines, so let's get it through the flu shots. Let's get it through everything else. So, my voice was removed off Facebook. I was banned, so, October of 2020. So, I think that it's important for everybody to have their voice and speak the truth.
Well, Facebook is run by the dark side, so we don't want to be on there anyway.
That's true, too. So, that's why we like to go to Rumble, too. Not YouTube, but Rumble.
All right, well, listen, thank you so much for this.
Thank you.
This and all CHD TV programming is made possible by generous support from viewers like you. Please consider making a contribution today to keep our programming going strong. Thank you.